Hello guys, I hope all of you are doing well. I'm Dr. Ranchan, your pharmacology faculty at Marrow, guys, and today we're going to discuss the recently asked MCQs in the INI-CET May 2025. Overall, the MCQs in pharma, they were moderate, right? With little bit of concept, logic, you could have solved these MCQs. All right, now let us begin with the first MCQ. An 8-year-old on carbamazepine, 800 milligrams once a day. She has taken the erythromycin for some infection, possibly, right? 1 gram OD daily for 2 days. Now she develops imbalance and gait ataxia. What is the cause? Now let us look at the options to begin with. Option A, she developed carbamazepine toxicity. Option B, she developed hypersensitivity reaction. Option C, she developed erythromycin toxicity. Option D, she developed relapse of epilepsy. All right, now let us look at these options one by one. From option D, she developed relapse of epilepsy. Guys, this is not possible. I mean, imbalance gait ataxia is not a symptom of epilepsy, right? She developed erythromycin toxicity. Now, erythromycin toxicity does not present as imbalance or gait ataxia. This is also wrong option. She developed hypersensitivity reaction is again wrong. Imbalance or gait ataxia, these are cerebellar toxicity symptoms, which is not a part of hypersensitivity. Though carbamazepine can cause Stevens-Johnson syndrome or rash is a part of hypersensitivity. So I can rule out and get the answer as she developed carbamazepine toxicity. Now, what is the reason behind this? Carbamazepine and another anti-epileptic called as phenytoin. Now, both these drugs, they are known for causing cerebellar toxicity. They are known for causing cerebellar toxicity, which in present is ataxia and dysarthria. And in this case, this is a presentation of cerebellar toxicity. Why that female or the kid developed is because she was prescribed erythromycin, which happens to be an enzyme inhibitor. What it did, it inhibited metabolism of carbamazepine, and that increased the risk of cerebellar toxicity. So it's an easy MCQ, guys, not a difficult one, right? All right, next one. Match the following: acute tolerance, reverse tolerance, cross tolerance. Right, let us see. What is the meaning of these tolerance? First of all, see what is acute tolerance. Acute tolerance is whenever I give high doses of drug to a person, all of a sudden the patient develops tolerance and does not produce adequate effect. For example, acute tolerance can be seen with alcohol or cocaine. So suppose there is a person who drinks or snorts cocaine, and all of a sudden he uses a dose of alcohol or cocaine and he does not get that kick. He does not get that response that he used to get. That is called as acute tolerance. Now, what is the problem with acute tolerance? Because the patient is not responding to the usual dose to which he used to respond, he will increase the dose of intake. Suppose he used to take some amount, let us say 1 milligram of cocaine, is not responding, you'll increase it to 2, 3, 4. And because of that, this can result in toxicity, or that is something we call as OD or overdosing happens in acute tolerance, right? Reverse tolerance. Now, what is reverse tolerance? Reverse tolerance is, as you can see the name, reverse. That means in tolerance, the response gradually decreases. Here, the response will increase. Now, reverse tolerance, where with multiple exposure of the drug, the effect begins to increase. It can be seen again with a drug called as cannabis. So in some people, when they consume cannabis, they used to get a high with a particular dose. Now, with a lesser dose, they'll get the same high. Now, what could be the possible reason? The explanation of cannabis having reverse tolerance is that cannabis is stored in our body tissue. So the next time you take cannabis, you'll not need that much of cannabis because your body already has that store of tissue, and that can lead to something called as reverse tolerance. All right, guys, what is cross tolerance? Cross tolerance is, suppose there are two drugs, A and B, and suppose I develop tolerance to A, that would automatically develop tolerance to B. This is called as cross tolerance. Now, let me give you the example here. The most important example here is again, let us talk about alcohol. Now, all of you know alcohol. With alcohol, what happens? It is a drug which acts upon GABA A receptor. So it's a GABA receptor modulator. With alcohol, what happens is I develop tolerance, And with continuous consumption of alcohol, the amount of alcohol that I need to produce the same effect, it keeps on increasing. Now imagine a patient who has been developing tolerance to alcohol was now one fine day was prescribed let us suppose a drug called as diazepam or any benzodiazepine, which is also a GABA A agonist. Now, here, because the patient has developed tolerance to alcohol, the patient will also develop tolerance to diazepam, and that is called as cross tolerance. And here, in such cases, I might need higher doses of the drug. So, guys, I've explained to you three types of tolerance: acute tolerance, reverse tolerance, cross tolerance. Now, let us match these options. So, what is acute tolerance? If you look at option A, B, and C, the best answer here is B, rapid tolerance developing with repeated use on a single occasion, such as a binge that happens with alcohol and cannabis. Reverse tolerance. Reverse tolerance is actually option C. Reverse tolerance is increase in response with the repetition of the same dose of the drug. That is reverse tolerance. So reverse of tolerance means the response will increase. Now, what is cross tolerance? Repeated use of the drug in one category confers tolerance to other drug. That is cross tolerance. So here I can see the answer is 1B, 1B, 2C, 3A, 1B, 2C, 3A. So option A is the right answer. Now here, again, if you would apply a little bit of logic, the definitions are not that difficult to understand, right? All right, guys, moving on to the next question. What is the function of phase 1 reactions in xenobiotics? Now, if you go back to the main videos of Mero, what have I taught you guys there about drug metabolism? Just let us recall a little bit about metabolism of drug. So did I not discuss that metabolism of a drug happens in two phases? Phase 1 and phase 2. Now, what happens with the drug in phase 1? Here, what I do is I break down the drug. So the drug is broken down. Now, once the drug is broken down, what I do, I attach a functional group to the drug as well. And this is how the drug attached with a functional group, it moves into the phase 2. So the drug attached with a functional group moves into phase 2. So why do I need this functional group? So guys, what is the name of phase 2? Phase 2 is also known as conjugation. Why is it called as conjugation? Because I need to attach a conjugate in phase 2. Now, I need something in the drug, right, that can bind to the conjugate. There is something is functional group. It is something that will bind to the conjugate. And the conjugate is always negatively charged, because of which the entire drug molecule in phase 2 becomes negative, or it becomes ionized, or it becomes water soluble. And water solubility is important for excretion of the drug. So there are two things which are happening in metabolism. In phase 1, I break down the drug and I attach a functional group. In phase 2, I make the drug water soluble. Now, up until now, they had been asking what is the purpose of phase 1 and phase 2. Your answer was break down the drug or make the drug water soluble. But this time, I never thought they're going to ask this MCQ, but I have taught you this in Mero. They attach what? Functional group. Now look at the MCQ. It's a simple MCQ. What is the function of phase 1 reaction? To make the compound more permeable. Wrong. To extract functional proteins. Wrong. To introduce functional group for further metabolism. Now this is a simple answer, guys. And if you have gone through the Mero lectures, it would not have been difficult for you guys, right? Oh, again, one MCQ. I've taught you this again in Mero. Which of the following statements is true about thalidomide? All right. Before I go into thalidomide, let us talk about what I've taught you in Mero. Thalidomide, to begin with, uses. What are the uses of thalidomide? You can look at the uses. The mnemonic is catch programs. So the uses are CLL, pancreatic cancer, rheumatoid arthritis, oro-ocular genital syndrome, or that is called as Behçet's disease, GVHD, renal cell cancer, AIDS-related wasting, multiple myeloma. Let me mark this while I'll tell you in a short while. Melanoma, myelodysplasia, ENL, let me mark this, erythema nodosum leprosum, and S for sarcoidosis. These are the uses. Now, what are the side effects? The side effects are in sport channel. So catch programs in sport channel. Sedation, phocomelia, or it is teratogenic. Let me mark it. Rash, thrombocytopenia, constipation. The most common side effects are sedation and constipation, right? Now, if I know this, now let me go back to this MCQ, right? Let me see whatever is correct here. It is immunosuppressive action is due to anti-metabolic effects. Guys, this is wrong. The reason being, drugs which produce immunosuppressive action because of anti-metabolic effect, these are either inhibitors of folate like methotrexate, or these are analogs of purine like azathioprine, or these are analogs of pyrimidine, or drugs that block pyrimidine synthesis like leflunomide. So these are the drugs which are anti-metabolite. Thalidomide is not. All right, what about other options? Multiple myelomide is used, correct? ENL, it is used, correct? Teratogenic, it is correct. 2, 3, 4. Option A is the right answer. So if you would have gone to the lecture, it would have been a cakewalk, isn't it? All right, let us have a look at this. Which of the following is true about GnRH receptor antagonist? Now see, GnRH receptor antagonists, these drugs are either they end with Golix or Relix. So what is the use of these drugs? Let us try to understand. Before I go to the MCQ, let us have a look at these drugs. See, these are either Golix or Relix, elagolix. Now, E for elagolix is a drug that is used for endometriosis. Why am I using it for endometriosis? Look at this. GnRH antagonists, they decrease release of LH and FSH, and they to decrease estrogen in females and testosterone in males. Now, because of this, I can use it in endometriosis because it is an estrogen dependent condition. Because it can decrease testosterone, I can use it in prostate cancer because it is a testosterone dependent condition. All right, two uses, right? All right, what is controlled ovulation? Let us have a look at this option. Controlled ovulation. Controlled ovulation, what is this? All right, now remember, whenever I go for IVF or in vitro fertilization, IVF, I need in the female for the follicles to develop, and for that I use FSH for development of the follicles, or I can use clomiphene. Now this is given for development of the follicle, not for the rupture, follicle development, right? And because of this, when the follicle develops, and there would be one follicle which is largest in size, that is called as a lead follicle, and that lead follicle, when it develops 14 mm in diameter, right, I need to prevent ovulation, because I need to time the ovulation at right time. Now, to prevent that ovulation, that is something called as control ovulation. And you see why ovulation happens? Because of surge in what? LH. So by giving antagonists, I'll decrease LH, and that will prevent premature ovulation, and that is called as controlled ovulation. So here I'm using it in controlled ovulation because of decrease in LH. So the uses of these drugs are either because of decrease in estrogen or testosterone or LH. These are the three uses of these drugs. All right, let us have a look at these options. It is used for treatment of hypogonadal hypogonadism in males. Now see, hypothalamus or pituitary, they don't have much role in hypogonadal hypogonadism, and in hypogonadism as it is, I'll not be using antagonists, right? It is used for management of advanced CA prostate, that is correct. Tocolytic is a nonsense option. It is used for controlled ovulation, that is also correct. So 2 and 4 are correct. Option B is the right answer. Moving on, which of the following drugs can cause cholestasis without portal inflammation, right? Let us see. This is something I have taught you guys in Mero lectures. Let me draw a hepatocyte. Suppose this is a hepatocyte, and this is my bile acid. And bile acid is secreted out of the hepatocytes by a pump called as P-glycoprotein pump, or it is also called as MDR1 pump, which is multi-drug resistance 1 pump. So bile acid, it would move out by this particular pump. Now, what happens with some drugs? Let me talk about some drugs like estrogen or erythromycin or cyclosporin. Now, these are bunch of drugs which also move out by the help of same pump. So when these drugs are given to a person, they will compete with bile acid. And what this is gonna do, this is gonna inhibit excretion of bile acid, and that can cause something called as cholestasis. Now, this is something I've discussed with cyclosporin. This is a PYQ which has been asked. Now they chose to ask about estrogen. Going back, what is the answer here? Estrogen and androgenic steroids, which can cause cholestasis without portal inflammation. Next, a 62-year-old male with AKI, acute kidney injury after cardiac surgery, was admitted to ICU with declining urine output. The intensivist administers Fenoldopam. So the drug is Fenoldopam intravenously. How does this drug help in improving renal function in this patient? Guys, again, two drugs we discussed in ANS. One drug is called as Fenoldopam, and another drug is called as dopixamine. And if you remember, I compared these two drugs. These drugs are common in one aspect. Both are D1 agonists, because of which they produce renal vasodilatation that leads to diuresis. Now, this is something that is common, right? That is something that is common. There is something that is different. Fenoldopam is also alpha-2 agonist like clonidine. Because of central sympatholysis, it is going to decrease blood pressure. Dopixamine, on the other hand, it is a beta-2 agonist which produces vasodilatation, and that is also going to decrease blood pressure. So I told you these two drugs, this is what is common and this is what is different. In this case, the drug that they have asked is Fenoldopam. Let us go back to the MCQ. Why this patient with lesser urine output, what was given Fenoldopam? Let us look at this. Option A, dopamine D1 receptor agonism causes dilatation of efferent arterioles, increasing GFR. Now guys, this is the correct option. Alpha-1 receptor antagonism causing vasodilatation is false. It produces alpha-2 agonism. Beta-2 agonism, bronchodilation. Beta-2 agonism is produced, is present with dopixamine, right? D2 receptor is wrong. This option, guys, D2 receptor has nothing to do here. All right, so answer is option A. Moving on, guys. A doctor wanted to calculate loading dose of a drug that is given orally. The loading dose will be dependent upon which of the following parameters. Let us see. See, loading dose formula by IV route. What is the formula of loading dose by IV route? How did I calculate this? Do you remember? Volume of distribution is equal to dose of a drug that is given by IV route to C0. C0, it is initial plasma concentration by IV route. Now, what is C0? Let us see. See, if this is time and plasma concentration by IV route, whenever I give a drug by IV route, at time 0, the plasma concentration is maximum. So this maximum plasma concentration is what is called as C0, that is initial plasma concentration. Now, this is the formula to calculate VD. Now, let me change this formula. Dose of the drug is equal to volume of distribution into CT. Now, CT here stands for target plasma concentration, target. For every disease treatment, I need a specific plasma concentration that is called as target plasma concentration, right? Now, for this target plasma concentration is always constant or within a constant range. Now, if a drug has a very high volume of distribution, to maintain a constant CT, I have to increase the dose of this drug, and this dose, high dose, is called as loading dose. So loading dose is equal to VD into CD. So loading dose depends upon two things, VD and CT, but condition applied, the route is which one? IV. All right. Now, let us go back to the MCQ. Is the route IV? No, oral. So if the route is by any other route, not IV, then what comes into picture? You see, by IV route, the bioavailability is 1. So here I can write this formula as like this: loading dose into F, bioavailability by IV route, is equal to volume of distribution into CT. Now here, F does not matter because by IV route, F is equal to 1. So you multiply 1, you do not multiply 1, it does not matter. But if I calculate loading dose into F by, let us say, oral route is equal to VD into CT, then by oral route, it is not 1. It can be 60%, 70%. If it is 70%, I'll say it is 0.7. If it is 50%, I'll say it is 0.5. So I have to take that into account. Now, this would be the formula, but to calculate loading dose, what I have to do, I have to divide VD into CT by F. So by oral route, loading dose will depend not only on VD, but also on CT and bioavailability, right? So if you look at this, you'll get your answer. What does it depend upon? Bioavailability, yes. VD, yes. Target plasma concentration, yes. Half-life, no. So 1, 2, and 4. So yeah, option A is the right answer, right? So many of you have marked only volume of distribution and target plasma concentration. If you have marked that, then it is okay. Go easy on yourself. This MCQ is a little bit on the difficult side, right? All right, guys. Match the following. Now see, in this MCQ, I'll be telling you how, if you know one thing, if you don't have no idea about 4 things, you don't know anything about all the 4 things, but you know only one thing, you can still solve such type of MCQs, right? If you remember, I've taught you this, that morphine, amphetamine, ketamine, these are drugs which have high abuse potential, and all of them, they belong to Schedule X, right? Now, if I know this much and I have no idea about what's happening with other drugs, so 3 would be A. Now, if I look at all the 3, there is only one 3 where there is A, and here, even if I don't know anything, my answer would become B, right? Now, let me explain the other things here. If you remember G, H, and X, these are things which I have talked about in humans. I've never talked about Z. I don't teach Z because Schedule Z is for animals. So that is one thing. Now, if I look at the remaining ones, so veterinary drugs would be Schedule Z. Vaccine and insulin, they belong to both G and X. So I can match to anything possible suitable. In the answer, if you can look at this, vaccine has been matched with B. Vaccine has been matched with Schedule H, that is correct. And insulin has been matched with C or Schedule G. So as I said, the vaccine and insulin are both G and X, G and H. Why? Because the Schedule H drugs are drugs that can be given with a valid prescription. Schedule G drugs are drugs that should not be taken without a medical supervision. So essentially, every Schedule H drug belongs to Schedule G drug, right? So answer is B, guys. So I told you how to find the answer here quickly. All right, which of the following statement is true regarding bempedoic acid? All right, let us see what is bempedoic acid. Now remember, cholesterol synthesis, it happens from citrate. 2 enzymes participate here. ATP citrate lyase and HMG coenzyme A reductase. So citrate forms acetyl coenzyme A, then to HMG coenzyme A, then cholesterol. The drug that we know are called statins. Statins are the drug of choice to decrease LDL. Now, in around 2020, a new drug was designed here that blocks ATP citrate lyase. Now, why was this drug designed? The reason being, see, statins, in some patients, there can be resistance to statins, and that is because of polymorphism in HMG coenzyme A reductase. So in some patients, the HMG coenzyme A reductase structure is different. Statins should not be able to block it. For that, we thought, why not block an enzyme before it? And we block this by a drug called as bempedoic acid. Bempedoic acid, which is a prodrug which forms bempedoic coenzyme A, and this blocks ATP citrate lyase. So whenever there is resistance to statins, what I do is I add bempedoic acid that increases the effect. Right? So this bempedoic acid is a dicarboxylic acid. And so what are the options here? It is a dicarboxylic acid, correct. It inhibits cholesterol synthesis, correct. It is used in dyslipidemia resistant to diet and hydrostatin. Now, option C is not correct. It is a non-competitive inhibitor. Remember, I've told you this, 99.9% drugs are competitive antagonists. That is the reason why competitive antagonism is also known as pharmacological antagonism. So here, bempedoic acid, it competitively inhibits this enzyme called as ATP citrate So it competes with citrate for this enzyme that is called as competitive inhibition. So it is answer 1, 2, and 4. 1, 2, and 4. Option A is the right answer. What is MCQ? A patient with depression was on a TCA. Imipramine was started on diphenhydramine antihistaminic for nasal congestion. Which of the following statements is true regarding pharmacological relationship between imipramine and diphenhydramine? Let us see. See, diphenhydramine is an H1 blocker, antihistaminic, right? But I don't prefer it much. Why? Because it is highly sedative drug. So mostly we use it as an anti-muscarinic drug. So diphenhydramine, more than antihistaminic, is preferred as an anti-muscarinic drug. Whereas, let us talk about this drug, imipramine. So imipramine is a tricyclic antidepressant which increases norepinephrine and serotonin by increasing their reuptake. Is a very good antidepressant, but the problem is imipramine blocks a bunch of receptor like muscarinic, H1, 5-HT, alpha-1. So imipramine is a drug that also blocks muscarinic receptor. So what is common with both these drugs, diphenhydramine and imipramine, are muscarinic blockers, right? So it's not a difficult MCQ. So what is the answer? Imipramine inhibits diphenhydramine metabolism. Wrong. Diphenhydramine inhibits imipramine metabolism. This is also wrong. Both block muscarinic receptors. That is correct. All right, guys. So here you can see there were very less repeats. INI-CET exam is like that. So those guys who are watching this and preparing for NEET PG, please don't get depressed. NEET PG MCQs are different, and they're an exam of different ball game altogether, right? So don't get depressed and watch this video, learn whatever you can, and then move on with your preparation for NEET PG. The days are less in number. And guys, my best wishes to all of you for the NEET PG. And those students, reminder to all of those who have performed disastrously in INI-CET, you can still get a very good rank in NEET PG. Please believe in that and move forward. Don't get depressed. Well, guys, that was Dr. Ranjan, your pharmacology faculty at Mero. Take care. Bye-bye.